What is up? What is up, everybody? Welcome to another episode of the Insomniacs Livestream with your host, myself, Dr. Andrew Kim. I'm a board certified psychiatrist. For those of you who are joining for the first time, I welcome you. For those of you who are regular listeners, thank you for always supporting me, for sticking in with me, even at these late night hours. And if you are not aware, the Insomniacs live stream on my YouTube channel, we do this every Tuesday night and Saturday night at 10:30 Central, 11:30 Eastern. We go for at least a minimum of 30 minutes if it's engaged and we have enough interaction. Sometimes we go an hour, or even longer. So today's topic, we're gonna, we kind of rotate back and forth between some pop culture topics and items. Today we're going to do something a little bit more serious, kind of grounded in the roots of psychiatry and mental health. We're going to be talking about understanding schizophrenia. We're going to walk through the nuts and bolts. So I hope that today, like this is something that I'm very passionate about. The area of schizophrenia is something I'm very passionate about. When I used to work as a principal investigator, which is just the term for a physician who leads, and oversees the clinical research at a research site or a research center. Schizophrenia was one of my just areas that I was always passionate about. And, that passion unfortunately witnessed a lot of clinical trials that failed and did not end up panning out to try to come up with new treatments. There were a few treatments that ended up passing, but many unfortunately kind of fizzle out when it gets close to getting FDA approved. But a lot was learned, from those experiences, and my heart really kind of goes out to those, who are suffering from chronic psychosis and schizophrenia, and their loved ones who are there to support them, and also kind of, bearing some of the burden, trying to support their loved ones. So I hope that today we can go over this. So whether you are just here to learn and just learn more about chronic psychosis and schizophrenia itself, just for educational purposes to raise your awareness. Awesome. I'm glad you are here. If you are someone who may be going through this, uh, it hopefully will be useful for you. And if you are a loved one, family member, a friend, someone who is helping someone who is going through schizophrenia or chronic psychosis, I hope that this is helpful to you. Whether it's just for your own understanding, for you to be able to better support that person. So let's kind of go through it, and please feel free, shoot questions in the chat. You see the text message line over there. Some people want to text me in private, but if you text me, I'm assuming you're okay with me reading your questions out loud. So send over messages as we're talking, and we're just going to go through a brief overview today. So let's just first talk about kind of, what is schizophrenia. Then we're going to talk about the evolution of the timelines of how things evolve. Okay. And then we'll kind of talk about the different categories of symptoms. We'll talk about treatments and some of the pros, a lot of the pitfalls and side effect concerns with the treatments. And then, we'll wrap up with some Q&A. Okay. So, number one, schizophrenia is probably one of the most well-known forms of chronic psychosis. Okay, chronic psychosis. It is a chronic psychotic disorder. Once the onset occurs, I would say for the vast majority of folks, I will say sadly, this ends up being a lifelong illness and a lifelong disorder that will need chronic management of some sort. Okay. And typically, and we'll go over it a little bit later, the symptoms and the disruptions are typically viewed in a few different categories. And the three categories we're going to talk about later are going to be a category called positive symptoms. This is probably the category that most are familiar with. Things like hallucinations, delusions, disorganization of thought processes. Another category of symptoms that people are probably less familiar with, unless you are in mental health or struggling with this yourself, they're called negative symptoms. And negative symptoms, we kind of use this verbiage, plus and minus, positive and negative, because negative symptoms are symptoms as if, part of you is almost lost, right? Like if you were to do a comparison and contrast of how you were functioning pre-illness before the onset of schizophrenia versus after, it's almost, these symptoms are almost kind of like the absence of or the subtraction of things that used to be there. Things like your spontaneity, your level of animation, your full spectrum of emotional expression. You're more withdrawn, right? So that kind of liveliness and that spirit is kind of diminished, right? Almost kind of it was subtracted away. That's why we call them negative symptoms. It can almost look like depression if one were to look from afar. And then the final category we call just cognitive symptoms. And I think this is one of the biggest misconceptions is when the lay public thinks about the term schizophrenia, we have this archetype in our minds, right? This archetype or stereotype of it's that person walking on the street talking to themselves. And we assume that hallucinations themselves or paranoid delusions themselves are what leads to disability or debility, right? And really, it is the cognitive aspects of schizophrenia which leads to most of the disability and struggles with work and academics, and that's important for us to talk about. So those are kind of the three categories. We'll go into more detail later. Okay, but let's talk about just the time course, like how does this evolve, right? How does schizophrenia evolve over time? And I will say there are differences in the onset for males and females. Okay. Now, this is not going to apply to every single person. These are general statements. I know people will say, well, that's not how it worked for me or for someone I knew. Again, these are general timelines. I would say for males who end up getting diagnosed or having their first break of schizophrenia, this tends to happen more in adolescence, mid to late adolescence to their early to mid 20s. That is kind of the general window of time for peak incidence. Okay. For women, you actually see that shifted. So for women, that shifted a little bit later, and you will see more of a peak incidence in their early to mid 20s to early 30s, actually. So kind of shifted a little bit later than men, again, generally speaking. So you are going to see these two different time courses. Okay. Now let's talk about the evolution, right? Is it almost kind of like a light switch that one day you didn't have the symptoms of schizophrenia and the next day you'd have the full-blown syndrome? Actually, no. So that's one of the first misconceptions we should talk about. What typically happens prior to what we use this term first break. And when we use that term first break, that means when you meet the full criteria for schizophrenia, meaning, having chronic, persistent, and pervasive hallucinatory experiences, delusional experiences, changes in your cognition, disorganization of thought. So prior to your first break is the term we'll use kind of, ongoing in this episode. There is a period of time where there is kind of the mild evolution of subtle symptoms, almost these hints or harbingers of like what is to come. And we call this period, this window of time, the prodrome, 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 or some people call it the prodromal period. Okay, and this is something that is not as well known by our public and our society. Now, here is the challenge. Here is the challenge of trying to diagnose someone in the prodromal period or during a prodrome. During a prodrome, you typically do not meet the criteria for full-blown schizophrenia. Okay. During a prodrome period, you may have subtle aspects of those positive, negative cognitive symptoms that we'll talk about. But this is what a prodrome may look like. During a prodrome, an individual may, in terms of their affect and their demeanor and their emotions, may say they're a little bit more down, depressed, a little bit more withdrawn. Facial expressions may not be as animated. They seem to have become more isolative. They're not maybe as engaged in their typical network with their friends, with their family, with their acquaintances. They're just not as animated as before. That can oftentimes be interpreted as depression, right? And so many people who are going through a prodrome may get diagnosed as being clinically depressed. Okay. Another aspect of what happens during this prodromal period is that some of the cognitive symptoms that we'll talk about in a little bit start actually happening during the prodrome period. There may be subtle difficulties with attention span, concentration and focus in their schoolwork, at the job that they work, maybe after school, after high school, or in college. There actually may be problems with what's called working memory, meaning you're trying to memorize something new or novel for the first time, and then 8 to 10 minutes later, you're asked to recite it back, and you're having challenges. You're drawing a blank. And why? When you're in your teenage years and your 20s, why are you struggling? It's not that you're having, signs of early dementia. It's just there's this phenomenon where people will report like my memory's off, my attention's off, my focus is off. And what do you think, right? When I say those things out loud, what do you think that inevitably gets diagnosed as? Typically gets diagnosed as ADHD or ADD, right? So it is not uncommon at all during this period, the subtleties of being more withdrawn, not as animated, being down, more isolative, maybe being even slow to respond, your spontaneity, the latency and onset of your speech, even your speech pattern. These things oftentimes will get diagnosed as depression, as ADD. They're just stressed, etc. And so, in fairness, right, for the field of psychiatrists, for psychologists, it is challenging because by the way we are describing this, folks do not meet the full criteria of schizophrenia, right? So it's not that something was glaringly missed. It is just so hard to detect. So on that topic, before we go on to the concept of first break, right? There has been research, there have been attempts to do what's called these early intervention studies, identifying people that we think meet this criteria for a prodrome of schizophrenia and trying to intervene, maybe even start treatment with antipsychotics. Hey, D77, thanks for joining. I'm glad you're here. We're talking about schizophrenia today. These early onset psychosis clinics, where sometimes even in this prodromal period, some programs and some clinics out there have opted to say, hey, if there are enough risk factors, we may even opt to treat you before you even meet the full criteria of schizophrenia. And of course, they're trying to factor in other risk factors. Do you have a family history of this? Maybe first-degree relatives who've been diagnosed with schizophrenia, etc. Now, the problem is, even to this day in the year 2025, we have not isolated specific chromosomes, specific chromosome abnormality, like one specific gene to say that, this is the risk factor to equal schizophrenia. Okay? And trust me, you'll go Google it, you'll look and say, oh no, there's these genetic links. Actually, in actuality, we're a lot closer to identifying a true like genetic inheritability component for things like bipolar disorder than we are for schizophrenia. The last I checked, and it's been a while, I'm not going to lie, I mean, we narrowed it down to like 120 something different allele or gene locations. Now do the math and think about how many variations that can equal. So we're actually not close to saying that these 5 gene locations or this particular chromosome abnormality equals schizophrenia. So as much as we'd like to think that we could simply ask, oh, is there someone in your family who has this, and then assume that one may get it, we're not there. I think we really, like in the field, we like to comfort ourselves thinking we have this black and white, all or nothing binary methodology of trying to, rule in and rule out things. Again, please, don't get me wrong. I'm not obtuse to the fact that, yes, am I more concerned if someone has a family history? Of course, because there is probably a increased risk. Is that a guarantee, though? No. So the problem is, even with this good intention, let's identify early, intervene early, treat early, maybe even preemptively treat before you meet the full criteria for schizophrenia. Noble as it may be, think about what we're asking people to do, whether it's the person themselves or their loved ones, right? We're saying, hey, you actually don't meet the full criteria for schizophrenia, but let's put you on a lifelong course of heavy duty medications that have tons of side effects. Hey, are you in? That's rough. That's rough, right? I mean, as noble as the concept is, pragmatically speaking, you said that to me, if you said that to my kid, and I'm like, wait, doc, so my son doesn't meet the criteria for this, but you think you're worried that it could happen? How about we wait until it actually happens? Let's cross that bridge when that happens, right? I mean, that's a tough sell. That's a tough sell. And I think that's been part of the issue with some of these, early intervention, like really early intervention type of clinics. Not that it's a bad idea, not that it's not noble. It's just, man, that's a tough sell. And when we talk about some of the meds, you'll understand why. We'll talk about them a little bit later. Um, but that's some of the challenges about trying to identify folks in this prodromal period, because again, you don't meet the criteria. Now, look, are there cases where, it's a little clearer to tell that maybe someone is on that pathway? Yeah, because in addition to some of the subtleties that I listed a couple minutes ago, there are some folks who might even start saying, like, hey, maybe it wasn't like these full blown, easy to describe, like visual hallucinations, but here and there, right? I'm having these sensory misperceptions, kind of walking the fine line of dissociation slash psychosis, right? Like I think I saw some shadow figures over there, right? I thought I heard my name being called, but it's not just that like paranoid feeling. I swear I heard it, but maybe it's not fully formed. Maybe it's not chronically happening. So look, if you have some of those cases, the fringes of like hallucinatory experiences, the fringes of maybe almost kind of these quasi delusional thought processes, but not with full conviction, in addition to the subtleties, of course, yeah, that may be a little bit easier to tell, right? The argument would be like, are you already so far in that prodrome that you're kind of on the brink of your first break, right? So that is the challenge. But to end this part of the conversation, there is a window pre first break, and that is called a prodrome. It is just challenging. It is challenging to identify this because it may look like depression, it may look like ADD at times or some kind of subtle cognitive issue. And then a first break occurs. Sometimes there could be precipitants, for example, and this is a general statement, okay? I'm not vilifying drug use, okay? So I'm just saying, let's say maybe you do have some inheritability risk. You had a mother, you had a grandmother, you had an aunt, multiple people in the family, solid diagnosis of schizophrenia. And then let's say you were already in a prodrome and you were having subtleties, and then maybe you decided to abuse drugs, maybe more than one should have, right? That may be a trigger to then kind of cross that line into a first break. Doesn't always happen that way. Doesn't have to be drug use. I'm just using that as an example. Sometimes there is no like landmark precipitant though. Okay. It can just happen out of the blue. And that is the unpredictable nature of also trying to predict when a first break would happens. Now, here's the thing. When you're in that first break, it is florid, it is acute, and you do meet full criteria for schizophrenia, essentially, minus the time component of having symptoms for months and months at a time. But I mean, in that moment, for weeks, for days, for weeks, you do meet criteria for schizophrenia, essentially. Now, here's the interesting part, and this is all it's interesting, but it also makes it challenging in the early goings, is that after this first break occurs, there is this window. There is this window where, even without treatment, even without antipsychotics, there's almost kind of this bounce back, this reprieve, almost a window where there's almost a little bit of a respite or improvement, where the symptoms either die down, at the very least die down, or sometimes almost vanish, where it almost seems like this was just a bad dream and a nightmare. Hey, I don't have this illness. Things are back to normal. Or let's say one did get hospitalized during their first break. What's also interesting is even minuscule doses, tiny doses of antipsychotics, like let's say even one fourth of what is typically used, oftentimes is a robust response. I mean, robust response that even a whiff and minimal doses of antipsychotics, not always, but oftentimes can produce a robust response and make the symptoms minimal to, again, almost nearly gone. Now, that sounds like a good thing, but here's the problem is that during that kind of like honeymoon period, I guess that's not really a good term for it, but like this window where you do see kind of this transient decrease in symptoms, that oftentimes leads to this debate from the person themselves or the loved one. See, it wasn't schizophrenia. It must have been sleep deprivation. It must have been stressed. It was just a breakdown, nervous breakdown. It was a temporary thing. Maybe it was that thing I smoked, but it was laced with something, right? And the mind scrambles because who wants to hear for themselves or for the loved ones? This may be a lifelong incurable illness. Nobody does. Nobody. So I'm not blaming anyone. I'm just saying that it raises this interesting phenomenon and challenge of almost this window where you almost feel like there's lived in experience. See, it's gone. And it makes it almost challenging then to retain those who are struggling with it or their loved ones and engaged in treatment because they're like, it can't be, right? Denial sets in. And again, not coming from a bad place. I wouldn't want to say to myself, I have a lifelong illness, right? And thank you guys. Comments are coming in. We'll take a pause in a minute here after we talk about first break, and we'll read some of these comments and questions. So keep them coming. But that's what makes it so challenging. Now, the problem is that inevitably, I would say for the vast majority, I'm saying 90 something percent, 90, I'm probably very close to 100%, that respite period, whether without meds or robust response to meds, eventually ends up wearing off, and gradually symptoms increase in persistence and pervasiveness. And then you just kind of chronically keep meeting the criteria for schizophrenia. And then we'll talk about the three categories in just a minute. That's the problem. So it's an interesting phenomenon that even right after your first break, you almost kind of have this window where it's symptoms, you kind of bounce back almost close to normal. And or the response to meds are so robust that one begins to question, do I even have this thing that the doctor keeps saying I have? Then we'll talk about kind of the three categories of symptoms in a little bit more detail. So let's go to some of these questions. And we got a lot of regulars here. So D77, I appreciate you coming back. Carrie and Dennis are regular listeners. So there's some comments coming in from some of you guys. So is schizophrenia more of a psychiatric or neurological disorder? Well, it's a good question. I guess it kind of depends on how you view it. You know, there are very few things in the field, and you guys have heard me. For you regular listeners, you know how I am quite critical of the DSM and how we arbitrarily kind of categorize things with, we're basically taking phenomenology, right? Clustering things together and then arbitrarily giving them names oftentimes, right? But I will say schizophrenia and bipolar disorder are some of the few things that I do believe that there is a structural, organic, however you want to phrase it, structural, organic, physical disease state or abnormality, right? Pathology that's happening that leads to and influences emotional, cognitive experiences. So I guess it depends on how you define that, Carrie. So if you're saying neurological, meaning is there true dysfunction in, I guess brain structure, nerve structure? My answer would be yes in that case, because we do believe that circuitry is impaired, signaling is impaired. I think sometimes maybe we're looking for the holy grail of like imaging results, but I mean, for whatever it's worth, there are some correlates of decreased white matter, in the frontal cortexes. We believe even things like hippocampal volume volume in general of certain areas of the brain. I mean, we see structural differences post-mortem or even with imaging over the course of lifetimes of patients who are suffering from this. So bottom line is yes, like we do believe, and with fMRI imaging, we do see differences in patients who have schizophrenia, how they experience their symptomology, and even when it comes to sensory perception. So I do believe there is true structural, physical, neuronal dysfunction that is happening. And I think we have enough evidence at this point that we can see that. And so I guess it depends on how you're defining psychiatric versus neurological. But I will say these are one of the few things in the field of psychiatry where I feel like, yes, there is definitive evidence of numerous structural abnormalities, signaling abnormalities that we can readily replicate and see. Now, causality is a different story. It's just we can see the actual dysfunction occurring pretty clearly. So, um, Dennis asked a question that also came in: is chronic drug-induced psychosis different from schizophrenia? Yes, yeah, I would say yes, because I guess one could say, right, at the end of the day, there probably is a Venn diagram and there is going to be some commonality where maybe you have caused enough irreversible damage to some of the dopamine tracks related to, let's say, positive symptoms, which we'll get to, like that can lead to hallucinations, delusional thinking, paranoia, that it almost looks as if there are, chronic psychotic symptoms similar to schizophrenia. I will say probably what will differ, in my opinion at least, is some of the cognitive difficulties that one would see in schizophrenia would differ from, let's say, folks maybe who are abusing enough hallucinogens or meds that could induce psychosis that leads to like chronic hallucinations, delusions. That's where there may be a Venn diagram and it may look like it. Okay, but I think that where there will be somewhat of a difference is some of the cognitive dysfunction with executive functioning that would differ. And I would say that's probably where that Venn diagram ends, and there would be some subtle differences between the two subtypes. But on that topic, Dennis, I do believe that schizophrenia itself is kind of a heterogeneous bucket of manifestations of chronic psychosis, right? And we just kind of use this term schizophrenia as this overarching term or conceptualization. But for those who have experience in working in mental health, you will see that schizophrenia has a wide spectrum of presentations. And when we talk about the three categories, what I want you to keep in mind as we talk about the three categories of symptoms is that some patients are going to predominantly have one particular category versus the other. Some will have a blend or almost an equal mix of all of the above. And that's why one patient who's struggling with this will not look exactly like the next. Okay. We have, hey, what's up, James? Thanks for joining. We have some folks where they may have very overt and very easy to identify positive symptoms, hallucinating, they're talking to themselves, they're having conversations nonstop throughout the day when they're awake. Other folks have no hallucinations at all, none. And their struggle is with disorganization of thought processes, thought patterns. James, I'm sorry to hear that. If that's the case, James, I mean, I know I don't want to sound super generic, but you really got to get some help, James. Okay. And I know you know that, so I'm not saying that in some judgmental or pejorative way. It's just, it's out of concern, right? So I really hope that, whether it's today, whether it's tomorrow, whether it's later this upcoming week, some way, somehow that you can try to get some extra help, beyond whatever it is you already have in place in terms of getting help. So to your other comment, Dennis wrote, according to psychiatrist Robin Murray, MD, amphetamine psychosis was first presented as a phenocopy of schizophrenia. But now we know that schizophrenia is not a disease, it is merely a syndrome. Um, well, I mean, I can understand, it says which can be caused by a range of factors, including drug abuse. Yeah, yes and no. I mean, so you kind of heard my spiel, Dennis. I believe there are many routes and avenues that one can develop chronic psychosis. So if we're saying chronic psychosis rather than the term schizophrenia, oh yeah, definitely. I mean, there are many variations of chronic psychosis. We have drug-induced psychosis, even things like chronic amphetamine abuse, right? You've probably heard of stories, right? I mean, you don't need a doctor to tell you, like people who, interestingly, after massive chronic hallucinogen abuse or LSD abuse, acid, etc., can for years even have ongoing trips and hallucinatory experiences. We have folks who have, psychosis from chronic alcohol use in the long run, right? I mean, we have folks with, and again, even talking about the heterogeneity of even within the realm of what we call kind of like chronic psychotic disorders, even non-drug induced, there's things called delusional disorder, interestingly, right? Schizophrenia, schizoaffective disorder. So there is a heterogeneity of even these chronic psychotic disorders that are not even in the drug induced category, right? So to my comment earlier, right, at some point we need to become a little bit more sophisticated um, in trying to recognize these subtypes and variations of chronic psychosis versus just kind of using this blanket term schizophrenia at some point. So D77 writes, I had my first panic attack on May 30th, 2010, when I was 18 from smoking marijuana, and I thought I had schizophrenia, but ever since I've suffered from panic disorder. It was scary. 6 years, no weed. Well, D7, here's the thing. Look, absolutely right. I mean, look, some folks, right? I mean, again, there's so many variables, right? Your genetics, your brain, your sensitivity, what strain of marijuana? Is it indica? Is it hybrid? Is it what strength, what potency? Did you actually smoke what you thought you smoked? Was it actually laced with something? Right? There's so there, there's so many factors. Some folks, right? And again, I don't vilify marijuana, right? I mean, for some people, it works. If it works, it works, right? If it calms your nerves, helps you sleep, helps you eat, whatever, right? So it's not coming from a point of judgment. But some folks, the thing that I always laugh at, right? People who like defend weed like as if it's like, you know, some spouse of yours that you need to defend their honor. Like, there's nothing bad about weed. Well, I don't know what to tell you. That's just called being obtuse, right? I mean, I've smoked marijuana numerous times. I sometimes depending on what I used and what form, it's like back in the day, like it's like, sometimes it just got sleepy, great. I felt good, giddy, creative, etc. Right? But I've had friends of mine, man, sometimes they're paranoid out of their minds. Paranoid out of their minds, right? I mean, one time, this is like a long time ago, right? I think this was in Denver. I think I was walking on the streets of Denver and, I just bored on a business trip, bored, I guess, and, went to a dispensary when, it was already legal recreationally there. Late at night by myself, just, outside, and then, smoke some, and then, I felt good for a while, and then all of a sudden, I got paranoid out of my mind. Got paranoid out of my mind. D77. And I was walking down the street trying to get back to the hotel, and I don't know why. And all of a sudden, I could have sworn that this dude was probably just some random stranger walking down the street. I could have sworn D77 that dude was out to get me. And that dude was following me. and he had malintent towards me specifically. So I started walking faster. I kept looking back and I'm like, oh, he's there. Who knows if he was there? Maybe he wasn't there, but I could have sworn he was still there. And I'm freaking out. Like you said, my heart is pumping. I still vivid remember my heart is pumping. I'm like, why is this dude still following me? So I'm like, and this is the crazy part, right? Then I'm like, all right, this is how I'm going to shake him. I'm going to act smooth. And then boom, I just cut across the street. I didn't even go at the crosswalk. I just cut across the street, clearly while under the influence, not thinking straight. I'm like, I'm going to lose him. And I just bolted across the street. Probably shouldn't have done that because it wasn't at a crosswalk, right? And then I'm like, okay, did I lose him? And I'm like jogging, running, got back to the hotel, freaking out. Uh, you know, so everyone has a different reaction, even the same person. Sometimes it's fine, sometimes it's not. So I hear you. I hear you. James, yeah, James. No, James, I hear you, man. I mean, I understand. Look, man, I can't really I can't give people direct medical advice, but what I can tell you right now from the sounds of what you're doing, you need help, James. Okay. If it's at the point of consuming things like hand sanitizer, right? Again, I'm not saying that from judgment, James, right? It's just kind of it says to the level of just how much, right, the disease itself, right, of substance use has got its clutches on you right now. And the fact that you're here, James, and you're asking me as a stranger, all these other folks here as a stranger, like, for some help, right? It tells me and all these other folks here, like ambivalence, right? The concept of ambivalence. Okay. And what I mean by that is when patients of mine that I actually treat as a doctor, I never say this phrase, James, to people, hey, don't you want to stop? Don't you want to quit? I don't even bother asking. I already know the answer. The answer is hell yes, you do, right? Hell yes, you do, James, right? You wouldn't be here. You wouldn't be here talking and commenting and asking for help if part of you wasn't yelling internally, I got to put an end to this. I know there's a part of you that does. That's why you're here. That's why you're making comments. So, what will it take? Like, what does it take to get yourself motivated to take that step? Because I hear you, man, fear and anxiety. I don't want cops involved. I don't want to get my civil rights taken away by being admitted somewhere. I don't want a huge bill, right? Hospital bill, all those factors, right? Man, all I know is all that stuff, ambulance bills, hospital bills, people giving you a hard time, getting judged, getting comments, getting the side eye, feeling shame, feeling guilt. You know what? I'm not saying that's good. I'm just saying your life is worth it, James. Okay. Your life is worth it. You are worth it. I don't know you, right? I'm not trying to be corny, man. I'm just saying you are worth it, man. All right. So you got to get some help. You got to motivate yourself to just take that step. Okay. I mean, even if just hop off this live stream, go get some help. Okay. I know, man. Nobody wants police involved with anything. I hear you. I hear you. So whether it's checking yourself in then, so you don't have to go the route of having people come over to your place, it's if you can get yourself somewhere safely without getting behind the wheel, if you can have a friend take you somewhere, if you could have a ride share take you somewhere. But I hope you get some help. I hope you get some help, James. So yeah, D77. I know that made me take a break. So trust me when I say I hear you, man. Right? You know what I'm saying, right? I'm the way you're saying it. You're not sitting here like being all high and mighty about like the evils of weed. It's just everyone's different. So I'm not judging me. I'm just saying. I just share that because I'm telling you, man. I know what it's like. So I had a freak out moment. I had a freak out moment. Okay. All right. So getting back to the topic, guys. So first break, right? So first break happens. We said prodrome, first break. You get that little window where symptoms may go down on its own or robustly respond to meds. And sadly, right, for almost every patient, most, gradual return of the symptoms. And then now you have the full syndrome, right? So when I say full syndrome, let's talk about the three categories. And again, the concepts are positive, negative, cognitive. Okay, those are loose terms, but those are kind of loose frameworks we think of. So we call it positive because it's almost like these things are happening in excess. So if you were to compare someone's functioning before their first break and after, these are things that are now here that shouldn't be. These were kind of like added to your framework, right, of thinking. These would be things like hallucinations, right? These sensory perceptions were not happening. Now they are. These were added as the plus symbol, positive. So now hallucinations, which are sensory experiences that are occurring, typically, I would say for the most part, they tend to be auditory. I would say it's a minority. It's not the majority. It's a minority of patients who have chronic visual hallucinations. And I would say even a smaller percentage with things like tactile or sense of touch, olfactory, meaning hallucinations of smell. Again, smaller percentage. If you're having chronic olfactory hallucinations, probably also want to make sure that epilepsy or seizures are not occurring. So, especially temporal lobe seizures. But so chronic hallucinations may be a positive symptom, and this is something that probably the lay public is most familiar with. Now, here's the thing, though. One comment on this before we talk about the other positive symptoms. It's this notion, right? It's a false thing to say that folks who are struggling with hallucinations are just imagining these. It is not about imagining, okay? Their brain, their nerve cells are interpreting as if there is a stimuli happening from the environment, even though there's not a source in the environment doing this, but they are actually hearing this stimuli. They are hearing sounds, they are hearing voices. And we have imaging studies, auditory studies that, yeah, James, you need to get help, James. And I'm not trying to be crass or dismissive. I mean, it's at that point. So good. Call crisis services. You need to get help. That takes a priority over watching this and making comments here. But you can sit here commenting while you're waiting them to come, but you got to get some help, James. So I'm glad that you called crisis services. Okay. So that's the thing, right? It's not imagining or, oh, they just think they heard something. No, they are hearing things. They are hearing these. And imagine now, right? Try to put yourself in the shoes of someone who's having auditory hallucinations, right? Imagine trying to focus on a task, focus at work, focus on school, focus on, concentration, attention, heavy task, and you are hearing someone talking to you in your ears over and over and over and over again. Sounds, music, voices, right? Sometimes this is observable, right? You can look at someone and you can see overtly they're talking back as if they're having a conversation with someone who's not there. Sometimes it's not that overt. Other times, patients can be cognizant, right, that doing that will draw a reaction from others. So sometimes you'll see their eyes dart off to the side, their head turns slightly as if they're responding to a noise and then kind of choosing not to respond, right? So sometimes it's going to be subtle signs like that. Other times it's going to be overt and you can see them responding, talking back. These can be intermittent, episodic, or constant. It's torturous for patients. Imagine the toll and impact it takes on you, just from an emotional standpoint, how it affects productivity, concentration, attention. So another positive symptom, things that are now here that used to not be there pre-first break, delusions. So delusions are not hallucinations. Delusions are fixed false beliefs that are not based in reality. So, and they could be all different subtypes. These could be paranoid delusions. There's a conspiracy against me. People are coming to get me. People are poisoning me. Everyone's spying on me. Right? I'm being tracked. I have a microchip in me. These could be romantic delusions. I'm married to X, Y, and Z celebrity. I'm having a baby, even though there's no evidence of pregnancy. Grandiose delusions. I am the king of the secret kingdom. No one knows my royal bloodline. I am a king, right? So there could be grandiosity. There could be paranoid delusions, delusions of persecution, all subtypes. So just delusions in general, right? And there will be variable levels of conviction, but typically some degree of conviction. And again, there can be a wide spectrum of these delusional beliefs. These could be general and vague in nature. I just know people are out to get me. They could be systematized with meticulous details. It goes way beyond they're out to get me. Oh, there's this network of spies. They work for the Russian government. They were then hired with contractors from Blackwater, and the Blackwater contractors rotate with a team of 8, and their names are Bob, Andy, Bill, and whatever. And it can go on and on and on. So it could be at that systematized, nuanced detail level. It could be vague in nature. Okay. There can be another set of positive symptoms are like disorganized behaviors, like disorganized, unpredictable, erratic behaviors, disorganized speech, incoherent, illogical speech patterns, jumping from topic to topic. These things are now happening that used to not be there. So they lump kind of this disorganized pattern of speaking, disorganized behaviors under the category of positive symptoms as well. So hallucinations, delusions, disorganization. So that is kind of the very quick and dirty of positive symptoms. Now, interestingly, this category, positive symptoms, are the most responsive to antipsychotic medications. Okay. Antipsychotic medications are marginally helpful for the other categories, if not almost minimally to almost not helpful, to be blunt. Okay. This is the category that can actually get the largest percentage chance of diminishment and improvement is the positive symptoms of psychosis or schizophrenia. Now, the negative symptoms, now again, we use kind of the minus symbol. That's why we kind of use this term negative. It's almost like these things have been taken away, which used to be there at someone's typical level of functioning prior to their first break. So these often get mistaken for depression. Things like alogia, that means reduced speech output, or poverty of speech. You might be giving one-word answers where you used to be very verbose. Okay. It might seem and come across as if they're not interested, they're being curt, they're being rude, but it could be a symptom of alogia where you literally have like this paucity of speech and you're just giving very short answers, one-word answers, couple-word answers. Avolition, a lack of motivation to initiate or complete activities. Again, that could look like depression. Anhedonia, an inability to experience pleasure and joy in everyday activities. Your facial expression, your demeanor may be flattened or blunted. Diminished emotional expressions. Even your tone of voice may become monotone and you might lose that natural prosody in your voice inflection going up and down, different emphasis. And you may sound and come across as robotic and flat. Social and behavioral withdrawal, right? Avoiding social relationships, interactions, hangouts with friends, with family, just kind of sitting in your room, keeping to yourself. So all those things, right? Whether it's reduced speech pattern, lack of motivation, lack of joy, flattening, isolation. Again, it may all look like depression, but it's more than depression. Because of what's going on in some of those frontal cortexes, right? We see this diminishment. Think about it, right? This is almost kind of at least akin or an analog to what you've read and heard about with like strokes or actual physical insults from trauma, right? Blunt force trauma, TBIs, major bleeds, strokes, as if personality has changed, right? And you have either known someone, heard of someone, witnessed someone, know someone in your family circles, social circles, where it's almost like, I hate to say it, but that term, right? They're almost like a shell of themselves. That spontaneity is gone. That spark is gone. Right. So we have some analogs to where when there is physical damage to some of the circuitry, depending on the area, you can see this occur as if they are a shell of themselves. They've almost lost a part of themselves, lost a part of their spirit. It almost looks like they're now depressed. Similarly, this type of pathology and damage from schizophrenia leads to this as a chronic state for a lot of folks versus it truly being like an episode of depression. This is part of the illness itself. And sadly, like I mentioned before, this category, the negative symptoms, oh, I would say I don't want to say all to be discouraged, I'd say, but for many patients, this area is rather resistant. That's probably the most appropriate term, resistant, and not as robustly responsive to antipsychotics as the positive category that we talked about, positive symptoms. And James, you don't have to be sorry, man. I think it's just me and everyone else. It's in order for you to get help, right? You gotta something like withdrawal from alcohol or alcohol type substances, that is potentially lethal. And so I hope you hear me loud and clear. You gotta get yourself to a medically supervised setting, even if it's the ER for some observation and getting some help and some treatment. So you got to get somewhere ASAP. Really do. Really do. Just like D77 is saying. So Carrie asks, so we'll pause here before we go on to the cognitive symptoms, says, I think most people have a quote inner voice where they think in words. Do schizophrenia patients just think they are physically hearing it versus just thinking it? No, I definitely, because we all have an inner monologue with ourselves, right? Like our thoughts almost play out like words internally, which is a different experience than the hallucinatory experience of schizophrenia. And I think it depends. I don't want to give a blanket statement. I think it depends on the individual. I think some folks over time and maybe with practice and getting more familiar with their symptoms can have the ability, and they could discern what are the symptoms of hearing, kind of the auditory experiences of their auditory hallucinations versus kind of that inner thoughts, kind of like folks without schizophrenia are experiencing as kind of their inner monologue or dialogue that they're having or their thoughts playing out. But other times I do think it can be confusing because to one of your earlier comments, Carrie, that I didn't have a chance to get to yet, is there can be impaired insight. Sometimes there is, sometimes there isn't insight into the illness of having symptoms of schizophrenia. I think that's just kind of the nature of delusions themselves, right? Delusions, to you, the individual going through the delusions, they're real, right? Even when people might give you evidence to the contrary, you are oftentimes prone to question that person who's questioning the reality of those thoughts versus questioning the reality of thoughts right away, right? And again, there are certain junctures and certain delusions and certain thought processes that one may question, but there are others that you may have full conviction. And so no matter what type of evidence is presented to you, that insight is going to be murky. Now, the final category, and this is really, to me, one of the most tragic categories, it's the category of cognitive symptoms. So again, positive, negative, cognitive. Okay. And the cognitive category of symptoms involve impairments in thinking, memory, problem solving, executive functioning, things like poor attention. It's hard for you to focus, pay attention, sustain your concentration on tasks at school, at work, on your daily errands. Impaired memory, especially working memory, trying to remember instructions that were given to you and then trying to do it and implement those instructions several minutes later. When I use that broad term executive dysfunctioning, I'm talking about things like planning, organizing, decision making, things that are multi-step in nature. somewhat abstract in nature. So abstract thinking in particular also gets very challenging. Processing speed itself, so delays in absorbing novel material, delays in understanding and comprehending what was just read, delays in responding to information, responding to questions, even in kind of a social setting or on a test, etc. So think about everything I just lumped in there: slower processing speed, executive dysfunction with organization, planning, decision making, complex tasks, abstract tasks, attention, memory. This category, this is the root. Okay, I'm not, again, please don't misunderstand. I'm not saying everyone with schizophrenia is disabled, but I'm saying this for those who are struggling and are struggling to hold down a job, struggling to succeed at school, struggling to run the day-to-day tasks of their lives. This is the root. This is the root of that disability. And that is something that is definitely not talked about enough by the public. That is tragic. It is the cognitive symptoms that prevent a lot of the functioning in the domain of schizophrenia. And our antipsychotic meds are not that great at treating this whatsoever. And when I talked about failures in clinical trials, and we need failures to then succeed. So I'm not saying failures at some like doomsday message, but a lot of the failures in the clinical trials for schizophrenia that I worked in when I used to be a principal investigator were in the domains of new chemicals and new compounds that were trying to treat negative symptoms and to treat cognitive symptoms. And you heard what I said. The sad part is it's the cognitive domain that leads to so much of the disability. Yet we don't really have good treatments. We have, again, I'm not saying perfect, don't misinterpret that, but we have decent methods of trying to reduce those positive symptoms, but those aren't necessary. And again, I'm not diminishing the distress that positive symptoms can cause. But research had shown, and even when we are surveying, interviewing, talking to patients who have schizophrenia, not saying that positive symptoms don't distress you, but they say it's those cognitive difficulties. It's what's holding me back from reaching my goals, from living my life. So hopefully that was helpful, just hearing that those are the three major domains and categories of the symptoms of schizophrenia. Now, again, back to Dennis's commentary, right? This is what I meant by the comment I made in response about heterogeneous subtypes. You will have some folks where the positive symptoms are the primary issue, most overt, noticeable thing happening, hearing voices, talking to themselves rather regularly, constantly. You have other folks, they're saying, hey, I don't have any hallucinations. I don't know why you keep asking me that from visit to visit, but they appear depressed almost constantly. They're withdrawn, one-word answers, not engaged, not interactive, keeps to themselves, very isolated. There are other folks who are going to manifest as the disorganized type, disorganized behavior, disorganized speech patterns, and thinking is most predominant. But here's the thing. Most researchers agree, and most experts in this field agree, that the common linchpin amongst even these various heterogeneous subtypes is the cognitive category of symptoms. And to your so to Dennis, so that's what I was referring to. Now that we've kind of talked about it, it maybe makes it fit a little bit better. To me, that's kind of where it's outside that overlapping Venn diagram with some of the drug-induced psychoses. It's this cognitive piece where you may not necessarily see that in some of the drug-induced psychosis, where you may see more of the positive symptoms of hallucinating, delusions, even disorganized behaviors. But this cognitive component I do think is what maybe sets it apart a little bit from some of the later in life onset chronic psychosis from chronic drug abuse and drug use, if that makes sense, Dennis. So hopefully that paints, somewhat of a differentiator of what doesn't always pan out that way, but a way that you can kind of almost see a difference between some of these subtypes. Now, let's talk about treatments. We're not going to talk about individual antipsychotics, but I just want to talk about them in general. Again, for those of you who may be wondering if these are appropriate for you for schizophrenia or know loved ones who have them. Again, bottom line, because this is a lifelong condition for almost most patients, I would say, the vast majority, more than likely there's going to be a need to be on these probably for a good portion of your life, if not chronic treatment. Okay. And I don't take that statement lightly because we're going to talk about some of the problems with these things. Like I said, what they can do and should do is very decently or hopefully robustly reduce the positive symptoms. And I've seen it myself in 14 years where patients are like, my voices are gone. Those auditory hallucinations are gone. Now, I will say, even in those positive symptoms, right? Hallucinations, delusions are a bit more resistant, sadly. Okay. Hallucinations, personally, my goal with the patient is I want to make those hallucinations either totally gone, or minimal, meaning minimal frequency, minimal distress. Maybe it becomes episodic versus every day, but we should get those robustly reduced. With delusions, a little trickier. I think that's going to be, I'd like to see that we can at least reduce the intensity frequency to the point where maybe there's also less conviction. But I've seen plenty of times where we were not able to necessarily have them go away completely. And that's where therapy is still crucial. Cognitive reframing. CBT is not just for depression and anxiety, but utilizing CBT to help kind of combat the remaining components, residual resistant components of delusional thinking that medications maybe cannot make go away completely. Okay. But so I also want to give that nuance that even though I'm saying meds can help the positive category the best, there's still even nuance of the subtypes of positive symptoms themselves of what these meds work better for and not as good for. Okay. But this is the category that can help. Now, negative symptoms, I would say antipsychotic meds, depending on the individual, maybe modestly help, somewhat help. There are cases, I don't want to sound pessimistic, there are cases where they do get better. We don't know why, and we don't know what differentiates that person who gets a robust response in the negative category versus the other who may just get that mild or modest response. We don't know. We just don't know. Okay. Cognitive symptoms, I will say, oh, that's rough. I would say it's not common. I will say that's probably the fairest way. It's not common that we get significant improvement. It's not. Okay. But still, right now, a staple med. And to keep this very simple, there are a couple of broad categories of antipsychotics, okay? The pre-1990s antipsychotics are primarily dopamine blockers, D2, so the dopamine 2 receptor or D2 receptor blockers. That's kind of what they do for the most part. 90s onward, we use this term, they're called atypical antipsychotics. And it's because there's a different ratio. These target serotonin receptors, they're called 5-HT, that stands for serotonin, 5-HT2A receptors, and they modulate those at a much greater degree than D2 receptors. So they modulate serotonin receptors, which has indirect effects on dopamine, and then they do still block dopamine receptors to some degree. This is a blanket statement for the sake of simplicity, and that ratio is different from the old school ones I mentioned that are primarily D2 blockers and maybe marginally act on those serotonin receptors. Now, there are a couple other new novel ones that have come out recently. but they're super expensive. I mean, like $3,000 a month where they're not affordable. But those, we can talk about those some other day, but these are the two subtypes. And then there's oral versions, and then there are long-acting injectables because compliance can be a problem. If you're struggling with those cognitive symptoms, remembering to take your meds, remembering to go to the pharmacy, navigating the healthcare system to get to your doctor's appointment, when is it? If something occurred like, cancellation or rescheduling, are you going to be able to remember that? Navigating your insurance and copays and coverages, and what if there's a prior auth that's needed or some kind of denial because of a technicality? All these different factors make it hard, in addition to lack of insight or impaired insight into the fact that I have an illness which I should be taking my meds for. So all these things combined lead to astronomically high non-compliance rates. So because of that, we also have long-acting injectables, intramuscular injections. There are 1-month versions, there are 3-month versions, there are even now, there's one that is a 6-month version. I know that sounds scary, but for those who are really having compliance issues, you work your way up to that from starting with a monthly injectable, 3-month injectable. There is one injectable called Invega, which is paliperidone. They actually have a 6-month version where if you work your way up to that, as long as you can get to the clinic for yourself or your loved one, you can literally get 2 injections a year and make sure that you're not missing your antipsychotic dose. Okay. Now, we could spend 3 hours talking about the antipsychotics. That's why I'm just kind of giving you the down and dirty, right? And then let's talk about the side effects, which in itself, this could be a 3-hour lecture in itself. Sadly, I used that term earlier, heavy duty. Yes, these are heavy duty meds because they have a lot of side effects. Now, we're going to talk about them broadly. We're going to talk about the pre-90s antipsychotics, okay? These are like Haldol, right? That's a well-known one, right? Trilofan. So but Haldol, like classic old school med, dopamine blocker. Then we're going to talk about the post-1990s to present atypical antipsychotics. They do less of that dopamine blocking directly, and they mess with the 5-HT2A or serotonin receptors. Okay, this is an oversimplification, but the old school ones, there's like a trade-off in side effects. The old school classic dopamine blockers, they have a higher risk for what's called dystonia. You can get it on your first dose or first few doses where you get an involuntary muscular contraction. Your back can just lock up and spasm. Your arms can flex and spasm and freeze. Your neck muscle might spasm. And I mean, it is painful and distressing. Like the muscles can lock up. That's called dystonia. Then you might need something called Benadryl or Cogentin to like unlock it and let it relax, okay? But dystonia is a muscular side effect that can happen immediately. Many of these have some variable level of sedation or grogginess, okay? So that we already said you already have cognitive issues, and now we're going to add a layer of drowsiness on top, which has its own problems with cognition. So that's great, all right? And then there's a risk of, and the longer the use, and with every single year, there is an increasing cumulative risk as well of something called tardive dyskinesia, TARDIVE, tardive or tardive dyskinesia. This is the development of involuntary muscular movements and contractions. It could be in your limbs, it could be like your fingertips randomly moving like that. Your toes can do that. Oftentimes, because this is the most visible area and a very sensitive area, you can see facial involuntary movements. Like you could see someone's nose kind of flaring, excessive blinking, corners of their mouth moving, tongue movements. You might see some folks who've been on antipsychotics for decades going jaw movement side to side. if you catch this early enough and you either reduce the dose, stop the med, switch to something else that may not cause it, it can be reversible. But if this is not something that the doctor is checking up on and you just keep plowing forward, it may become permanent even if you were to lower the dose or stop the med. That's tardive dyskinesia. Okay. So Parkinsonism, which is something people are familiar with in lay public, can be another thing that happens short term, intermediate term, because if you think about it, at the core of Parkinson's is dopamine deficiency. And if we're artificially blocking dopamine with antipsychotics and we overdo it too much for an individual, we can literally induce medicinally induced Parkinsonism. So I have witnessed and seen patients, in an ER setting, in an inpatient hospital back in the day when I used to work in those settings, where because of their chronic psychosis or acute psychosis, they were started on antipsychotics. And literally the next day, they're shuffling down the hall with these tiny shuffling steps as if they were someone with advanced Parkinson's. Or they'd be sitting in the day room watching TV and they would be resting their arm on the arm of a chair watching TV, and you just kind of see a classic resting tremor, Parkinson's. Their face the term is mask faces. Like, it's almost like they're wearing a mask. You don't see changes in their musculature and smiling, spontaneous changes. You even go through some exercises saying smile, and they can't even smile. You do these tests and screeners, like you have them put their arms out to the side and you tell them let it drop to gravity. And if you say drop it, let it go loose and hit your sides, like you should just hear it just go down like that. And then when you have someone who's having these side effects say stop, then you see it go down like this because of the muscle rigidity going down very slowly. So we would actually see Parkinsonism evolve in front of our eyes. And definitely that is a urgent concern, and you would then have to lower the dose, stop the med, reverse its course with other, medications, etc. And it'll go away. It is not permanent Parkinsonism, but it is antipsychotic induced Parkinsonism. So these meds have significant side effects beyond even just I didn't even cover your more standard fare: dizziness, nausea, constipation, right? I mean, these have all the standard fare stuff, but these are some of the unique, when I use the term heavy duty side effects, right? These are the things you have to worry about with old school antipsychotics. Now, how about the new generation, right? People are like, well, then we must have evolved and we must have better stuff now from the 1990s to present. Well, yes and no. So I will say, again, as a blanket statement, the newer ones, right? I mean, you're talking about, aripiprazole or Abilify, Latuda or Lorazepam, all these newer antipsychotics. It was almost a trade-off. And here's what I mean by trade-off, okay? Head to head, as like two broad spectrum categories, right? Even within the categories, each are different. But as a blanket statement, the newer generation ones do have a lower head-to-head risk of some of those neuromuscular issues, lower risk of long-term tardive dyskinesia, those involuntary tics and movements, lower risk of inducing Parkinsonism when you're using the appropriate doses, okay? So there is a lower risk of like muscular and neuromuscular issues. That is clear. No one disagrees with that. Okay, not zero, but lower risk compared to the old ones. So that's the good news. Now here's the bad news. And again, not that the old ones are immune to this or don't have a risk of this, but the newer ones, as a general statement, minus a couple of exceptions, like maybe aripiprazole or lorazepam, but I would say minus a couple that are lower risk. The vast majority of the newer antipsychotics in 1990s onward, like Zyprexa or olanzapine, Seroquel, which is quetiapine, these are well-known ones. The trade-off is these have a higher risk of metabolic concerns in the intermediate and long run. And when I say metabolic concerns, I mean decreasing your insulin sensitivity, raising blood sugars. So this equals diabetes risk, weight gain, increasing your cholesterol, irrespective of your dietary habits. So independently as an independent risk factor of raising your cholesterol. So what did I just say? Increased risk of weight gain, increasing your cholesterol, increasing your blood sugar and diabetes risk. What does that equal? Weight gain, increased cholesterol, increased risk of diabetes. Long term, that equals increased cardiovascular risk, right? That's we're setting people up for metabolic syndrome. In addition to the standard fare side effects of drowsiness and nausea and constipation, and there's still going to be risk of neuromuscular symptoms. So this is a decision not to be taken lightly. And I feel horrible. I feel horrible because it's almost kind of like a damned if you do, damned if you don't. Because let's have a fair and balanced conversation, right? Like, I'm not trying to vilify these meds. I prescribe them right now. But you got to have a transparent discussion with your patients, their loved ones. Got to let them know what they're getting themselves into, right? The risk-benefit ratio of uncontrolled, unchecked symptoms that are disrupting their life, causing them distress, dysfunction, versus the side effects that can lead to problems with their health down the road. It is not an easy discussion, right? But to be fair, why do it if there's all these risks? Because there is some evidence. There is some evidence that when unchecked and you have these peaks and these spikes or these decompensations of symptoms flaring up that may even worsen your functioning more than the chronic symptoms are typically doing week to week, month to month. Like, let's say you enter a chapter of your life where you're decompensated and the symptoms are even more severe than usual. Okay. There is some evidence. I don't want to say it's fact, but there's some evidence that when people suffering from chronic psychosis have these unchecked episodes that flare up and they decompensate even beyond their typical level of functioning with their chronic symptoms, there's some evidence that some irreversible nerve cell white matter damage may happen. And there may actually be some brain nerve cell loss each time one of those decompensations occur. And again, is this mythology and just a ploy to get people to stay on these antidepressants? No, there's some evidence of this occurring in some patients. So, there is concerns that later treatment, meaning let's say someone who had legitimate schizophrenia for 20 years started on their meds 20 years into their illness versus someone who maybe right after their first break started on their meds, there is evidence that has shown that there tends to be better response rates to these medications and better long-term symptom control with early intervention. So back to going full circle, back to my commentaries about the challenges of trying to intervene very early or too early when people are in prodromes, there's still merit to that concept though, because we do have a decent amount of evidence. We have a decent amount of evidence to show us that at least after a first break, the sooner you intervene after a first break, we seem to have improved outcomes with functioning, symptom severity, level of sensitivity and responsiveness to medications compared to someone who's delayed treatment for years or decades, finally started on their treatment way down the road. So there may be somewhat of this kind of, I don't want to go overboard, but almost kind of a neuroprotective phenomenon of keeping your symptoms in check as early as possible, soon as possible with early intervention versus waiting way too long before seeking treatment. Okay. So I want to at least end with that because, again, I know I said a lot of scary, nasty stuff, and I don't want people scared away from treatment. It's just got to make sure when you're getting help, you have these very explicit adult conversations. It is overly maternalistic, paternalistic as a clinician to not have these discussions with their patient or their loved ones because they got to know what they're getting themselves into. And I think as long as you can convey to them, I have your best interest at heart. I'm not going to lie to you, though. I'm going to have these very explicit conversations. You and I, as partners, as teams, it's teamwork. We got to make a decision. There is no perfect pathway. It's like crappy choice A, crappy choice B. We got to make decisions in your best interest together. Let's have these difficult conversations. That's the way we got to do it. Can't hide these things from people, right? So that's the challenge. That's the challenge. The challenges are early identification is challenging. It's sobering that our treatments tend to be decent for one out of the three categories, mild to modest for one, and then basically not very helpful for the cognitive category, right? So, and they have so many side effects that all these things make it so difficult to have these conversations and to keep people in treatment when the treatments in themselves have an impact on people's quality of lives. And that is a challenge when it comes to long-term treatment of schizophrenia. So, last comment, and then we'll open it up just for some free time for maybe 10 minutes, getting late. Right. I hate how our news and our mainstream media news cycles, still to this day, even in the year 2025, some mass shooting happens, some violent crime happens, and the automatic assumption is, oh, must have mental illness like schizophrenia. Right. And they'll latch on to that immediately. And sadly, you know what that is? That's more about us as human beings wanting to make chaos and randomness and horrible, vile, horrific deeds make sense. We want it to make sense. There's got to be a reason it happened. The idea that random evil can occur without predictability, without a way, without seeing a warning sign, I think that's just unsettling for some people. I've just come to accept that's reality. That's how life works. But some folks cannot live with that idea. So we got to put a causality on it, right? And they always go, oh, that person must have had schizophrenia, likely had signs of schizophrenia. The parents missed it. It's the parents' fault. It's the system's fault. It's the school's fault. It's the doctor's fault. They probably had schizophrenia that was undiagnosed. False. Not the case. Depending on what you read and what you believe, like in terms of statistics, what I can say as a very blanket general statement is that patients who are suffering from schizophrenia are way, way, way more likely to be the victim of a violent crime than to be the perpetrator. I'm going to bore you with the raw number. Go look it up. Go look on the DOJ's website. Go look on HHS website. Go look at whatever solid, neutral, valid source. The percentages may differ. Some will say 2, some will say 14 times more likely to be a victim than an actual perpetrator, okay, of violent crimes. But no one seems to disagree on all these different sources that they are more likely to be the victim and be taken advantage of due to their vulnerability, their symptoms that lead to dysfunction, that leads to some disability. They are being typically taken advantage of versus the other way around. And my heart goes out to them. This is why we've made strides. Don't get me wrong. We've made strides as a society with mental health acceptance, mental health discussions, less stigma, but there's still a damn stigma. And sometimes the most vulnerable of us are still getting the most stigmatized. And that's where my heart it's heart-wrenching, right? When something terrible happens and they're like, oh, must be because of schizophrenia, must be because of chronic psychosis. Quote unquote, a normal person never do that. Yeah, actually, tons of crimes happen. People who don't have a chronic mental illness. I'm sorry. That's reality. I think it's just our media and our lay public. We want to sleep easier at night knowing there is a causality of the violence out there, right? Sometimes these are just people doing bad things, guys, right? And so we need to change the narrative, right? That almost puts this like villain-like connotation with the term schizophrenia. not to sound corny and cheesy, but I just, I can't stand that narrative. I really can't. But so I'll end it on that. So Carrie says, let's open it up to Q&A before we wrap up for tonight, guys. So hopefully you guys found that summary helpful. If you are not as familiar with the concepts of schizophrenia and chronic psychosis and its symptomology, its evolution, its timelines, from prodrome to first break to the chronic nature of these symptoms. So Carrie says, you mentioned antihistamines. I've occasionally taken OTC antihistamines for sleep, but I've read that they have anticholinergic burden, which can cause dementia. Can you do a stream? Yeah, I can try to, bring that up. Yeah, I mean, there have been some studies that have come out over the years. I mean, there's nothing, I'm not saying anything revolutionary. You've probably even seen some of these in headlines where even chronic benzodiazepine use has been linked to being a risk factor for increasing risk for onset of certain subtypes of dementia, Alzheimer's dementia. There has been, some literature on chronic anticholinergic burden, as you're mentioning. So there have been some studies on that. But, not all antihistamines are created equal. Some antihistamines have more, anticholinergic properties than others. So, but yeah, but again, even with the literature that is out there, these are very loose findings and very loose observational, I would say even loose correlational kind of outcomes or conclusions. So I would not go as far as saying cause and effect. But there have been some concerns, obviously, because we know for a fact that the cholinergic system is related to, kind of the pathophysiology of dementia, right? If I were to egregiously make a mistake and, give someone who has Alzheimer's dementia an anticholinergic agent like cogentin, which is benztropine, which is very anticholinergic, you can see a worsening of their symptomology and their cognition even further than the pathology that they're already dealing with because of their dementia, meaning we can see it worsen with agents that are anticholinergic. And then obviously some of the meds that are meant to slow down the progress of Alzheimer's, right, are, for lack of a better, procholinergic in nature, right? So, but no, it is an interesting concept, and I know there have been studies on that. But right now, I would not go as far as saying cause and effect by any means. Okay, so just been some commentaries and maybe loose associations, and most of the studies will say this should be studied more rigorously and in a better powered way. I mean, that's what the conclusion is for a lot of those, including like the benzo studies that I was kind of mentioning. So. Okay, couple more minutes left because, even for an insomniac like myself, it's getting late. It's almost midnight here in the Chicagoland area. But man, so we had a strong audience today. I mean, I think we had like 12, 13 people almost for the entirety of the stream. So I appreciate so there's definitely more than some of the core folks here because I know that D77 and Carrie and Dennis have been commenting. So there's got to be at least another, 8 of you out there who've been watching for almost the entire stream. So what other questions? Last couple minutes, last round of questions. Doesn't have to be about schizophrenia, but since you guys stuck it out, any other questions for Q&A before we call it a night, guys? Otherwise, we'll wrap up and then see each other again on Tuesday after the Super Bowl, and we'll see who won the Super Bowl, I guess. So, for you conspiracy theorists out there, you think the NFL is setting this up for a Chiefs and Travis Kelce win that, Travis Kelce and Taylor Swift can run out into the middle at the end and have a kiss, maybe propose to each other. So, oh, hi, Lisa. Glad Lisa from the Northwest. Thanks for joining, Lisa. Glad you were able to join again. So hopefully you caught some of the discussion today about psychosis and schizophrenia and the symptom subtypes. Bill's Mafia said, James, I hope you can get some help so that you can be in a better spot, even if it's while it's in the hospital watching the Super Bowl. So I hope you get some help, James. You really need to go get some help. So glad you're still here talking and commenting, but make sure you get some help today or tomorrow as soon as you can. D77 will catch you Tuesday as well. Thanks for joining. Thanks for joining, Lisa. So last call. last chance for questions before we wrap up for tonight. We'll give it a few more seconds. Otherwise, guys, I appreciate you. Thanks for joining. I know you are, James. I know, man. So, again, not coming from a seat of judgment. It's just, I wish I could do it for you, man. I wish I can drive you to go get some help myself, but it's just, you got to get, no one can do it for you. You got to take that first step. And I hope you get some help tonight, man. So make sure you try to go do that. So, all right, guys. Well, we'll wrap it up. You guys all have a good night. Thank you again for joining, and I'll catch you guys on Tuesday on the next episode. And D77, go Chiefs and go Mahomes for you. So we'll see how it plays out tomorrow night. Have a good night, everybody. Catch you on the flip side, everyone. Be safe out there. Thank you again for joining.